My name is Cliff Rosedale, and welcome to this presentation on risk-free deployment of photographic technology in melanoma diagnosis. Now, I have conflicts of interest. This book has a section on the deployment of photographic technology, and these two posters accompany the book and are available on these YouTube channels. Now, just for context, this is my context over 48 years of melanoma diagnosis. And you can see for the first 30 years, I diagnosed very few melanomas. That was partly because they weren't as common back in the 70s and 80s, and partly because I wasn't using dermatoscopy. And I started using dermatoscopy in 2005. That's the green part of the graph. And I started using serial digital dermatoscopic imaging right from the start. I didn't have a facility for total body photography until 2017, and I didn't start doing total body photography using detection software until 2021. Now, we're talking about the risk-free deployment of photographic technology, but first of all, I will mention targeted monitoring, which does involve theoretical risk to the patient. Now, this is when you have a lesion. This one was pointed out by the patient as new. She was a young woman, and it didn't have any dermatoscopic concerns, so I elected to monitor it for 6 months with her permission. And in 6 months, it had changed considerably. It was now chaotic, it enlarged, and it had the clue of white lines. And it, in fact, was a thin invasive melanoma with an excellent Breslow a Breslow thickness of 0.3 millimeters and an excellent prognosis of a melanoma less than a millimeter diameter of a 20-year, 97% disease-free survival prognosis. And this was a melanoma on the far left of the timeline we see here, where lesions cannot be diagnosed by dermatoscopy or clinically. They can only be diagnosed by serial imaging showing change. This was a featureless melanoma at its first contact. Now, targeted monitoring, I just will mention, because it involves the risk of monitoring a possibly invasive melanoma, only monitor flat lesions with low risk based on morphology, monitor only reticular or structureless pattern lesions, not clot pattern, because a clot pattern melanoma has been shown to grow more rapidly. And I suggest providing and documenting the option of excision rather than monitoring when you're doing this, and it's necessary to make sure the patient comes back. Now, with respect to risk-free photographic technology, the first option is repeated total body photography with manual or automated detection. Now, here's a man, 37 years old. You can see here that the total body photography has been repeated after an interval of 5 years, and the red circled lesion has changed compared to the baseline. And we looked at this dermatoscopically, and it did have some peripheral clods indicating growth. And although it wasn't particularly concerning, morphologically we excised it, and it was a melanoma in situ on the far left of the diagrammatic timeline. Now, this young lady was 41 at the time this lesion was encountered. It was a high-risk patient with 6 previous melanomas, 1 a nodular at age 29. Now, you can see here the arrows point to a lesion which has changed over a period of 4 years. It's not a lot of change, and it's a very small lesion. And this was encountered and diagnosed actually by my nurse, Christine Lee. The software, the PhotoFinder software, did not detect this change. She detected it by manually comparing all of the images on the total body photography. And dermatoscopically, it wasn't a very remarkable lesion. The vascular pattern is consistent with the background dermal plexus, and it's got a structureless brown pigmentation overlying the lesion. It certainly hasn't got strong features of melanoma, but we excised it, and it was a thin melanoma with a Breslow thickness of 0.3 of a millimeter. Again, on the far left of the timeline. This one's actually published in the book Dermatoscopy and Skin Cancer. In case you're concerned that it might not be a melanoma, here are the images courtesy of Sarah Wallace showing a thin invasive melanoma. And we published that with Christine as the first author. Now, the second type of technology I'm going to talk about is patient examination using total body photography as a baseline reference. So here we have a 49-year-old male. Notice these are not old patients, they're young patients. This is a lesion encountered in 2023 in his left popliteal fossa. It's a symmetrical lesion. It's not chaotic. So we looked at his images from 6 years earlier, and it wasn't there. So this was a new lesion. So we excised it, and it was a thin, invasive melanoma, Breslow 0.5 of a millimetre. On the left-hand side of the timeline, no features of melanoma at all. This is a 56-year-old female, again a young lady, and in 2019 we encountered this lesion. Dermatoscopically, it's symmetrical, completely symmetrical, but it has the concerning dermatoscopic feature of peripheral clods, which indicate that it's growing. So we went back to her images from 18 months earlier, and there it was, a fraction of the size of what it is now. This symmetrical melanoma was a thin invasive melanoma, 0.3 millimetre Breslow, associated with a dermal nevus. Now, you will note that dermal nevi are the most common nevi associated with melanomas, and dysplastic nevi are the least common. That's another subject. This was again on the left-hand side of the timeline. It is published in the book Dermatoscopy and Skin Cancer. Now, this is a 49-year-old female. This lesion was encountered in 2021 because she pointed it out as new. Now, it's a very subtle lesion. We went back and looked at images from 4 years earlier, total body photography images on Photo Finder, and it was there. So it wasn't a mosquito bite. It was something which had been persisting and maybe getting more evident over 4 years. So we excised it, and it was another thin, invasive amelanotic melanoma. According to the algorithm prediction without pigment, if a lesion of concern, which means you can't give it a confidence-specific benign diagnosis, and all the patient's concerned about it, if it hasn't got any vascular pattern, you excise it. And that's what we did. And this was another one on the complete left-hand side of that timeline. This is on a 43-year-old male's thigh. It's encountered. We compared with the previous images from 5 years earlier. It's quite a bit bigger. And it does have a few concerning dermatoscopic features. It is chaotic, and it's got a couple of peripheral tiny clods, and it was another thin, invasive melanoma. This one's not completely on the left-hand side of the timeline. I've put it straddling between featureless and very early features. The third method of risk-free total body photographic technology is serial dermatoscopic digital imaging of randomly selected lesions in high-risk patients. Now, here we have a 25-year-old female. She's very young. She has a family history of melanoma. She's got multiple moles. And so we decided to randomly monitor 6 nevi on this lady. Now, one of these had a melanoma arise in it within 6 months. Nothing at 3 months, but a melanoma within 6 months. Can you pick which one of these nevi would have a melanoma arise on it based on morphology? Well, it was D. You can see on the lesion on the far right, there's a little cluster of black dots at the top of the lesion. This was the only dermatoscopic change. It happened at 6 months, and it was a melanoma in situ arising in an nevus. Now, the top panel shows the melanoma with confluent lentiginous melanocytes at the basal layer and pagetoid spread, and the bottom panel shows the melanoma on the right and the nevus on the left. That is the most benign looking nevus you will ever see. It's not dysplastic in any way. It's just a congenital type nevus. No transition between the nevus and the melanoma. And this was a melanoma in situ on the left-hand side of the timeline. This is also published in the book Dermatoscopy and Skin Cancer. Now, you remember this case I showed you of the young lady with the lesion on the arm that my nurse, Christine Lee, detected. The photo finder missed it. Well, this is the same lady. Her name is Julia here, and that's her twin sister. Their father died at age 30 a week before they were born. They have multiple nevi. And we have been examining these ladies very frequently for 16 years now. Now, when we first met them in 2009, Julia had this lesion on her right popliteal fossa. We just managed that randomly along with multiple other pigmented skin lesions on both of these young ladies. There was nothing concerning about it. It was completely symmetrical. The border was that of a nevus all the way around. And from 2009 to 2013, it had changed, but it was still completely symmetrical. We accepted that. And then in 2016, it had become asymmetrical. We excised it, and it was a melanoma in situ. And it was on the left-hand side of the timeline. No features of malignancy dermatoscopically. This is also published in the book Dermatoscopy and Skin Cancer. Finally, I'm going to show you something which I haven't seen reported before, and that's serial digital dermatoscopic imaging of total body photography with detection selected lesions in high-risk patients. So this is where, instead of randomly selecting lesions, we are selecting them based on the fact that they've been detected as changed in the total body photography with the detection process. So here we have a 62-year-old man, and you can see the yellow arrow on the right, the yellow circle on the right, highlighting a lesion which has changed over 4 years. And the baseline dermatoscopy was not particularly concerning, so we elected to monitor it, and by 12 months it had changed enough for us to cut it out, and it was a melanoma in situ. Here we have a lesion on the right ear of a young man, age only 31. At the 4-year repeat total body photography image, you can see there's a very small change. And this is detected, and we have decided to monitor it. You can see at 12 months, the top part is the same, the bottom part is enlarged. 27 months, that's progressed, and 30 months we excised it, and it was a melanoma in situ arising in a nevus. Another young man, 41 years of age, over 5 years, the photo finder has detected change in a lesion indicated by the arrow. When we looked at it with the dermatoscope, it was not concerning. We monitored it at 6 months. We weren't too concerned. By 12 months, we were convinced it was changing progressively. We excised it, and it was a melanoma in situ. This 60-year-old female, over 5 years, the photo finder detected a change in the lesion indicated by the arrow. At baseline, it wasn't too concerning. At 30 months, it had changed significantly enough for us to excise it. A melanoma in situ arising in a nevus on the left-hand side of the timeline. Now, this lesion on the foot was discovered after repeating total body photography after 6 years, not by the photo finder technology, but by the nurse. And you can see it here on the right foot indicated by the arrow, a very small lesion, but it wasn't present earlier. And you can see dermatoscopically it was not very concerning at all. At 9 months, we weren't too worried, but by 16 months it was changing progressively. We excised it. Melanoma in situ arising in a nevus. Now, this young lady is very high risk. She's 35 now, and when I excised her first melanoma at age 13, it was a melanoma in situ on the forearm. Now, that's extremely young to have a melanoma. Then at age 21, I excised an invasive melanoma from her scalp in the anterior part line of the scalp, and at age 26, I excised another invasive melanoma on the posterior part line on the scalp. So she was having 6 monthly total body skin examinations from the age of 13. Over that time, from 2017 on, we monitored 36 randomly selected lesions. This is normal long-term monitoring of a high-risk patient, and it included the lesion on her upper back just below the tattoo marked by the arrow. You can see the monitoring from 2017 to 2020. The lesion is involuting. It's going away. This is what nevi commonly do. We stopped monitoring it in 2020. When my nurse, Christine Lee, examined her with me, as we always do together, she starts at the back, I start at the front. And she noticed that this lesion, marked by the black arrow just under the tattoo, was now as big as the lesion below it, marked by the blue arrow. Now, I didn't take a clinical photo at the time, I wish I had, but that lesion now was as big as the one below it. So we took another dermatoscopic image, and it had changed significantly. So we excised it, and it was a melanoma in situ arising in a nevus. So that was really, really interesting. We didn't know of any publications that show a melanoma arising in an involuting nevus, which we had detected. So we published that, and of course, Christine was the first author on that publication. What advantage does photographic technology add? Well, we say it gives us increased diagnostic sensitivity. We've shown you a lot of lesions, a lot of melanomas in the last 10 minutes, which were symmetrical, small, early, detected by photographic technology, and most of them were invasive. Most of them were small invasive melanomas. So here we have the left-hand side of the timeline, things that can only be detected by photographic technology. You can't detect them by dermatoscopy. In fact, this publication on scarred data from 2013 showed that small melanomas with a diameter of 3 millimeters or less were more likely to be invasive than larger melanomas. So detecting these very early melanomas is important. As well as giving us increased diagnostic sensitivity, using photographic technology gives us increased diagnostic specificity. So we come to these two young ladies that I've been examining now for 16 years and counting. And I show you multiple lesions, some of which we were monitoring randomly and routinely. We were just monitoring them every 6 months, some which we excised straight up. Can you tell which ones of these are melanomas and which are nevi? Well, maybe you can now if I tell you all the ones at the top are melanomas and all the ones at the bottom are nevi. And look at the type of nevi. They have milia-like cysts, right? They don't have terminal hairs, which they might have, but they have milia-like cysts as a clue to the fact that these nevi are hamartomas. They're not dysplastic nevi. They are congenital malformations, congenital type nevi. These ladies were said to have dysplastic nevus syndrome. In fact, they have multiple congenital nevi. And just to show you this point about specificity, over that 16 years period of time, we've managed 90 lesions, of which 18 we excised straight up, of which 5 were melanomas. 72 we monitored randomly, not targeted monitoring, random monitoring, because all their nevi looked scary. So we just randomly monitored. And of the ones that we monitored, we cut out 12. 4 of those were melanomas, 8 were benign, and 60 excisions were spared. 60 lesions survived. So 13 lesions excised in total, of which 9 were melanomas over 15 years. The number needed to treat was 3.3. And we confirmed that 60 lesions were biologically indolent and we left them. That's how you reduce overdiagnosis. But not everyone agrees. This was our paper about the melanoma documented arising in an involuting nevus after cessation of monitoring. And this was a reply from Wallace and Muir. And they made the statement, we live in an era of overdiagnosis. Could this be one such? And they referred to this paper of theirs, Melanoma Diagnosis at a Specialist Dermatology Practice Without the Use of Photographic Surveillance. They were quite proud of the fact that they don't use photographic surveillance. And their conclusion was, traditional melanoma surveillance with immediate biopsy of suspect lesions results in a high in situ to invasive ratio. That's what they do. Then they say studies using photographic surveillance show lower ratios of in situ to invasive disease. So, according to Muir and others, if proponents of phototechnology diagnose a melanoma in situ, that suggests overdiagnosis. Whereas, if they diagnose and have high rates of melanoma in situ diagnosis, that's evidence of diagnostic superiority. Think about that. Fascinating. Our response to Wallace and Muir was that in this particular patient, with the melanoma arising in an involute nevus, over a 16-year period, we excised 4 lesions, just 4, no more. 3 of those were melanomas, and 1 was a nevus. 35 excisions were avoided by serial dermatoscopic digital imaging. SDDI, that's monitoring, prospectively identified biologically indolent lesions, reducing overdiagnosis. That's what we stated in our reply to their paper. Thank you.